navigating colorectal liver metastases together. Colorectal cancer, or CC, is rising exponentially worldwide. It's the third most common cancer ever diagnosed. In Malaysia, it is the number one cancer diagnosed in male and second in female after breast cancer. This highly treatable cancer has good prognosis if detected early. Screening has played a pivotal role in bringing down mortality and morbidity in patients. Unfortunately, 70% of CRC are diagnosed at a later stage. That is at stage 3 or stage 4. At 70%, liver is the most common site of metastasis. This complicates treatment and demand a much more complex treatment. That is the reason why we have chosen this case today. Ladies and gentlemen, to prepare the onslaught, we have to equip ourselves with experience, skills, guided by the latest evidence so that we can provide treatment outcome for our patients. We need to deal this together. This morning, I'm very pleased to have my esteemed who are sitting right in front of me, which will deliver their talk respectively. I'm glad to introduce first Ms. Diana, Mr. Tharveen, Mr. Yong, Mr. Farul, Dr. Khairia, and Dr. Nick Farhan, whom I have immense pleasure to work with. Without wasting time, I would like to invite the first speaker, Ms. Diana, who will be assisted by Dr. Nick later during their talk. Ms. Diana, can I invite you to the stage now? You present.
Okay, Assalamualaikum, a very good morning to everyone, to Mr. Zairo and all my fellow colleagues and all the medical students. So I will start with the case presentation for today's Grand CPC case. This is a 57 years old gentleman that came to our emergency department with a chief complaint of abdominal distension and obstipation for 5 days. Patient actually came with a progressively worsening abdominal distension for 5 days duration, associated with a complete absence of passing motion and flatus for that 5 days. It is associated with nausea and vomiting, which patient said the vomiting was minimal in amount, bilious in content. Prior to that, patient also has 3-month history of constipation. Otherwise, he denied any altered bowel habit. Patient also has loss of appetite and unintentional weight loss, about 6 kg over the past 3 months. However, there was no abdominal pain, no perectal bleeding, no tenesmus, there was no fever, and there was no further history of similar episode in the past. Review of vital system was unremarkable. There was no significant past medical illness. There was no known history of inflammatory bowel disease or colorectal polyp. There was no known history of malignancy for this patient. There was no previous abdominal surgery. Patient was not on any regular meds or any supplement. There was no family history of colorectal cancer of hereditary polyposis syndrome. And for social history, patient was a non-smoker, has a balanced diet, and has a sedentary lifestyle. So on physical examination, when we examine the patient at emergency department, patient looks dehydrated. There was no pallor, no jaundice, and patient was not cachexic looking. Vital sign was fairly stable. Patient was afebrile. On abdominal examination, the abdomen was distended, abdomen was soft, non-tender, there was no mass felt. However, on percussion, there's a tympanic sound, and from the auscultation, there's a presence of hypoactive bowel sound. From digital rectal examination, we can't feel any anorectal mass. So in summary, this is a 57-year-old man present with a 5-day history of abdominal distension, obstipation, associated with a nausea and vomiting, and a 3-month history of constipation with unintentional weight loss over 3 months. And from the clinical examination, we can find that there's a distended abdomen with a hypoactive bowel sound. All this clinical history together with the physical examination brings us to an intestinal obstruction, which is most likely from the large bowel. So our first differential diagnosis that we were thinking during that time was an obstructed left-sided colon cancer. Why we say this is because Number one, the age is more than 50 years old. The symptom is gradually worsening, progressively worsening. There's a red flag symptom, which is the unintentional weight loss and loss of appetite. And there was no previous abdominal surgery to rule out addition. The differential that we were thinking during that time was sigmoid volvulus, colonic volvulus, either sigmoid or cecal, diverticulitis with a stricture formation, or colonic pseudo-obstruction or Ogilvie syndrome. So we were thinking sigmoid volvulus will be less likely because there was a red flag symptom, which is the unintentional weight loss. And it is less common in patients with without a predisposing factor, such as neuropsychiatric disease or patient on laxative abuse. And for diverticulitis with stricture formation, we're thinking less likely because patient does not have any history of diverticulitis episode before. And the obstruction, the patient's symptom currently was not preceded by a sign of any acute infection. And we were not, it would be less likely of a Ogilvie syndrome because the red flag symptom, as well as patient was not hospitalized, patient was not immobile, or patient was not critically ill. So for a patient with came in with an intestinal obstruction in emergency department with the physical examination, as I have mentioned before, we admit the patient, we resuscitate the patient, we keep the patient nil by mouth, we started IV fluid for hydration, and we started IV antibiotic and correct the electrolyte. At the same time, we also took blood investigation and we did some imaging. So the investigation that we actually get from the patient, the hemoglobin was normal. There's slight leukocytosis, which might indicate ongoing infection. Platelet was normal. The urea is slightly raised, could be due to dehydration. Creatinine is normal, which indicates there's no acute kidney injury. There's no electrolyte imbalance. The albumin was low, 26, which might indicate because of the patient has been not taking orally for the past 1 week. Otherwise, all the other liver function tests was normal. Then subsequently, we proceeded with imaging, abdominal X-ray, and CECT abdominal pelvis, which will be explained by Dr. Nick Farhan.
So let us have a look at the radiology assessment. The first thing that we look at is the radiograph. This is a chest X-ray. Of course, I think the main finding is in the abdomen, but while we are looking at the chest, with the thought of this could be a malignancy, we should assess for any signs of metastasis into the thoracic, such as pleural effusion or any lung metastasis. At the same time, we are also thinking of preparation for surgery. So we look at the cardiac status. So there's no cardiomegaly, and the lung is quite clear, and there's no interstitial disease. And the main findings is in the abdomen. So this is a stack of large and small bowel obstruction. So what we are seeing now is dilated loops of bowel, central and peripherally located, and some of them has stripes that extend from wall to wall, thin stripe that extend from wall to wall in keeping with valvular conniventis, which is seen in a small bowel obstruction, as well as incomplete extension of the opacity from wall in keeping with Hostra, which is seen in large bowel obstruction. So this is a large and small bowel obstruction. And what we are looking also is at the region of rectosigmoid, where there is paucity of bowel gas, meaning there's obstruction possibly in the left-sided abdomen. While we are looking at it, we also look for any signs of bowel ischemia. We look at signs of pneumatosis intestinalis, any air in the lining of the bowel, which we don't see, or any portal vein gas. So if there is aeroporta, we can see branching of air resembling the portal vein system. Those are seen in bowel ischemia in very high grade of obstruction. And then we have a look at the CT. So I'm going to scroll for you. So we are looking at the liver, and the first finding here is the ill-defined lobulated hypodense lesion in the segment 7, right? Solitary. There's only one. There's no bowel dilatation. There's no biliary duct dilatation. And then, as we have seen in the chest X-ray, those are the dilated large bowels and small bowel. And if we trace from the descending colon, this is the descending colon, splenic flexure. So there is an abrupt termination here with the presence of an enhancing mass in the distal in the sigmoid colon. Okay. This is the coronal view. Again, the main finding is large bowel obstruction with the presence of enhancing mass in the abrupt termination of the dilated descending colon. The hepatic lesion is seen in the segment 7. We can see it here. And it is a subphrenic or subdiaphragmatic lesion. Again, still image of the lesion. It is 2.3 centimeters in thickness and 5 cm in length. And here again in a coronal view of the lesion. And this is a still image of the hepatic lesion in keeping with hepatic metastasis.
So with that CT scan finding, we actually decided to go in for a laparotomy, exploratory laparotomy. So intraoperatively, as you can see from the images, there's actually a tumor, ulcerating tumor, which caused puckering to the medial mesocolon, adjacent to the tumor. And from here, from this picture, if you can see, it's actually adhered posteriorly to the retroperitoneal structure, which is we think it was a psoas muscle as well as the left ureter. And from here, we can see the small bowel was grossly dilated, congested, and edematous, indicative there's a chronically obstructed bowel with an incompetent ileocecal valve. Otherwise, there was no peritoneal nodule, there was no palpable liver lesion, so we decided to proceed with the diverting transverse colostomy. So we decided to proceed with the proximal diverting transverse colostomy. Since intraoperatively we did not took any tissue sample for biopsy, so we did an endoscopy assessment prior patient discharge where we did a sigmoidoscope, and I'm sorry, I don't have any images. We found there's a fungating tumor about 25 cm from the anal verge, occupying the whole circumference, which is endoscopically obstructed. And the HPE confirmed to be adenocarcinoma. And prior discharge as well, we took a tumor marker, which shows there's a raised carcinoembryonic antigen with a level of 132. Alpha fetoprotein was normal. Subsequently, we actually did a multidisciplinary team discussion between the colorectal unit, the oncology, as well as the radiology. And we have decided to give the patient neoadjuvant chemotherapy for at least 8 cycles. And we plan to reassess the tumor response as well as to determine the resectability of the primary tumor as well as the liver mets after the 6th cycle with the CT. So patients subsequently underwent neoadjuvant chemotherapy, 8 cycles of Xelox. Then we actually repeated the CT scan, which will be presented by Dr. Nick Farhan again.
Okay, this is the second CT scan if you can still remember the image of the first, let us have a look at the liver lesion. Okay. The liver lesion is now smaller and less defined. And there is a presence of stoma. And there is, of course, resolution of the bowel obstruction that we've seen in the earlier CT. Oh, yeah, sure. Okay. I'll show you the still image to compare between the two, the first and the second CT. And all right, so this is the lesion now in the sigmoid colon, much smaller and more defined. Okay. There is also a new lesion in segment 6 of the liver that is not seen previously. It measures less than 1 centimeter. And yeah, those are the main findings. So the tumor is much smaller now compared to previous CT. And this is the current hepatic lesion in the subdiaphragmatic region, segment 7, compared to previous CT. So the previous CT images at the bottom row compared to the current CT.
So after the restaging CT, we did another MDT discussion between us. So we have decided to do a 2-stage surgery for this patient. Two-stage surgery for this patient. The first stage, we actually proceeded with the open anterior resection with the en bloc resection of the left psoas muscle. So as you can see, this is the anterior resection specimen. Basically, this is the sigmoid colon with the upper rectum. There's a puckering of the tumor with the adjacent mesentery involvement. So you can't really see the central vascular ligation because the mesentery all clump up here. And posteriorly, we can see this is the psoas muscle, which we took as an en bloc resection. And this is the dissection of the specimen. This is the tumor with a 5 cm margin proximally and 10 cm margin distally. The intraoperatively only adhered to the left psoas muscle, but there's no adherent to the left ureter. So the second stage, we proceed with, we actually need help from our HPB colleague, which they did a segmental hepatectomy. And we actually closed the loop colostomy. We reversed the loop colostomy, where intraoperatively they can see this is the lesion. It is a non-anatomical wedge resection, the segment 7-8, with the size of 3 times 2 cm. So from, we did not invite any pathologists, so I will just present the HPE finding. So the HPE specimen of the anterior resection with the en bloc psoas muscles shows as a residual adenocarcinoma, which is moderately differentiated. And it is infiltrative into the adhered skeletal muscle, which is the psoas muscle. This gives rise of the T4B stage. The lymph node that we were able to harvest was 23, all was negative. So give us the stage of N0. There was no perineural or lymphovascular invasion. However, there was a tumor cells as seen at the cauterized margin, which indicate the circumferential resection margin was involved, which is here. This was the psoas muscle. Inferior to it, this part, which is at the cauterized margin, which involve, there's a tumor there. So overall, the TNM staging was T4B and 0. Why they wrote YP in the HPE report just indicate it's a post-neoadjuvant pathology staging. So for the HPE of the wedge resection of the non-anatomical segment of the liver, segment 7 and 8, it is a metastatic adenocarcinoma with a nearest surgical margin of 1 mm, and from the morphological and immunohistochemical features are consistent with colorectal in origin. So subsequently, we actually get help from our onco colleague to proceed, most likely refer them for a systemic chemotherapy, which will be discussed further by Dr. Khairiyah.
Right, thank you so much to Ms. Diana and Dr. Nick Farhan. So we have know about the case, diagnosed and subsequently managed this patient. So we have resected the colon tumor, given the patient neoadjuvant chemotherapy, and subsequently also resected the liver and reversed the stoma. So it is important to know, especially to medical students, even though we have labeled this patient to be a stage 4 colorectal liver metastasis, but all hope is not lost. So that's why I think it is important to understand this disease, that it is a treatable with the advancement of chemotherapy and surgery skills. So to understand this management better, to shed some light further, I would like to invite the next speaker, Mr. Tharveen, to the stage to elucidate to you all about the treatment strategy. Thanks.
So hi, good morning everyone. So I'm here today to talk to you about colorectal liver metastasis, just a brief overview and concepts. So before we even dive in further into this topic, right, I'm sure there is a lot of myth that probably you have heard before coming here, that stage 4 cancers are uncurable. So probably you have heard things like, liver mets means stage 4, terminal, we can't treat. You may say surgery for liver is too risky, rarely successful, or if it's too large or multiple, surgery is not an option anymore. Or like in the movies, the doctors come and tell the patient, I'm sorry, there's nothing much you can do for you because the cancer has spread to your liver. So today, our intention here is to break those myths and show you what are the facts that actually pertains to colorectal liver mets. So colorectal liver mets is not like breast cancer, because breast cancer is stage 4, the intention is palliative. But in colorectal liver mets, there is a role for curative intention. So that is our aim here today, to break that myth. So I'm going here to talk to you about some facts and statistics to convince you that colorectal liver mets, if you do something about it, there is a significant overall survival improvement. Just some principle of management, a bit on pre-rehab, and some take-home messages. It's very difficult to cramp up everything, an overview on CLRM in 10 minutes. So I'm going to give you 3 take-home messages today. At least that would give you an idea to grasp the concept of colorectal liver mets. So let's go into statistics. So obviously 22% of these patients will have liver metastasis at presentation. And unfortunately, 80% of these patients are actually unresectable at the start. And if you only give systemic therapy, the 5-year overall survival is only about 10 to 14%. But if it's a resectable liver lesion, if you offer surgery, for example, the overall survival can go up to 24 to 58%, averaging about 40%. So you can see there's a 3-fold higher survival improvement. And obviously, liver is the dominant site of metastasis, and second will be the lungs. You can even have a synchronous liver and lung at the same time as well. So the take-home message number 1, if you ever see a colorectal liver mets after this, do you do something or do you keep calm and do nothing? So obviously you refer to us, the colorectal team, or to the oncologist, because I have shown to you that the survival definitely goes up with something in terms of treatment tailored to the patient. And it is not the death sentence to this kind of patient. So it's not the end of the world if we give surgery or systemic therapy tailored individually to the patient, we can achieve a good overall survival. So the principal treatment in this liver metastasis in the background of colorectal cancer would be based on the umbrella of the MDT. So the MDT will consist of the colorectal surgeon, the oncologist, the radiologist, etc. So number one, we need to know what is the primary tumor and what is the degree of symptoms of this primary tumor giving these patients. What is the site and the volume of the mets? Is it resectable? Is it unresectable? And obviously, what is the patient's functional status? If the patient is too frail, can't even walk, with a poor ECOG status, obviously you need to do something about it before even thinking of surgery or chemotherapy. So these tables just simplify you the algorithm on how do you manage colorectal liver mets. You don't have to look at it so much. You just look at the first two tables. The first questions you ask is the primary tumor symptomatic, regardless the metastasis, whether it's resectable, is unresectable, it doesn't matter, is the primary tumor giving problem? And this problem can be in the form of bleeding, perforation, or obstruction. So if the patient comes to you with a PR bleeding and there is a colon or a rectal tumor, you need to know where is the tumor, how advanced is the tumor, and what is the rate of bleeding. Because patient can present with profuse bleeding or like chronic bleeding causing anemia over time. And your options would be either you have to resect the tumor, or if in the rectum, you can afford to give RT or even embolization. If it's perforation, it's quite straightforward. It's either tumor resection or diversion. And the aim in perforation is basically to septic control rather than the oncological resection. In obstruction, like in this index case that Diana presented, is about 30% of cases. So obviously the option will be either you can resect the tumor, you can offer diversion like in this case, or stent, or even bypass. And whatever that you offer the patient has to be tailored to the patient. For example, if you're going to offer stent to a patient, you need to know what is the patient's life expectancy. If this patient is a good ECOG status, going to live more than 6 months, you may not offer stent as a not as a bridging, more of a palliative. You can't do that because stent has its own patency rate, probably less than 6 months. So you need to tailor the management according to the patient. So you need to look forward a bit before deciding what you need to do for the patient. If the tumor is not causing problem, meaning it is not bleeding, it is not obstructed, it is not perforated, you do not do anything to the tumor. Because 20% of the time only this patient will need palliative intention. Because if you do something to the tumor, there is a possible 30% morbidity and 6% mortality. And studies have shown that there is no overall survival benefit. And if you do surgery and the surgery causes complication, there will be delay in systemic therapy and there's a risk of surgical complication. So two big trials to support this will be the synchronous and the CCRE4, which have shown there is no improvement in overall survival in upfront tumor resection in a metastatic unresectable liver mets with colorectal cancer. So second question you ask yourself is the liver mets resectable? So I'm sure the next speakers will talk about the criteria for resectability. I'm not going to go into that. But if the tumor, the liver metastasis is resectable or unresectable, we will start with resectable in terms of colon cancer. Obviously, this is from the NCCN by the Americans. So you can offer them 3 options. And all these 3 options have shown to have equivalent oncological outcome. I'm sure the next speakers will tell you how to choose this. But in general, you can either go in for a synchronous or stage resection or with local therapy, or you can give chemo first and then do the resection followed by a adjuvant chemotherapy, or you remove the primary tumor followed by chemotherapy and then you remove the liver mets. And obviously you complete with the adjuvant chemotherapy for a perioperative of 6 months. So this is to be for colon. If it's unresectable in colon, obviously, like I told you earlier, it will be systemic therapy, and then you keep on re-evaluating whether is there a possible conversion to resectability. If not, you have to deem the patient palliative. But in rectal, it's a bit different because you can see here, the first line would be offering neoadjuvant. So this can be in the form of chemotherapy, but the addition of short course and long course will be the difference compared to colon. And obviously, if it's unresectable rectal, it's going to be systemic therapy, just like I mentioned in colon earlier. So this is a table offering all the strategy of treatment options in liver metastasis. I'm not going to go into this much, but I'm going to just show you. As you can see, when you start from resection and then you slowly go down from RFA to microwave and lastly chemo, right? Can you see there's a significant drop in terms of the overall survival? So obviously, like earlier when I told you only systemic therapy gives you a survival rate of 10 to 14%, actually it's very true. So if you offer surgery, obviously you can offer the best overall survival to these patients. But in some patients, obviously you cannot offer surgery, then comes RFA and MWA and etc. etc. But you must understand, as you go lower, obviously the survival will drop. So the take-home message number 2 would be you tackle the primary tumor first if symptomatic, and if you have a liver metastasis, you tailor your management according to what have been mentioned, whether stage synchronous, neoadjuvant, or systemic therapy if it's unresectable. So we have gone through the 2 things, and the next will be the functional status of the patient. So most of the time, this patient may come in cachexic or malnourished or sarcopenic. And just want to highlight you on this cachexia, and refractory cachexia. So this kind of patient, when they come to you initially, they might be in the pre-cachexic state. Why is it important is you don't want them to go into the refractory cachexia state, because once they are already in that, the ship has sailed. There's nothing much you can do. So if you want to do something, you need to tackle the patient at the pre-cachexia state or cachexia state, because if you do not optimize the patient properly, whatever you're going to do hereafter in terms of surgery or systemic therapy is not going to yield you that overall survival that you expect to see. So most of our patients that comes to our hospital, they are already sarcopenic, whether they are elderly sarcopenia or obesity sarcopenia, and they already has a progressively worsening functional status. And now you add on cancer to them. So you know cancers actually deprive your body from the nutritional fuel that you need to fuel your metabolic functions. So this patient now will adapt to a lower BMR rate, reduction of function, and slow deterioration. For example, if you see a patient comes to you on a first day of clinic walking, after colonoscopy, CT scan, after a month, the patient comes to you on wheelchair. Most of us will tell this is disease progression. You know, the patient is going to succumb to disease. But most of this time, what happens here is this. Because the patient is malnourished and the BMR now has dropped and the body is slowly going into a catabolic state. So if this is the time you do not intervene, this patient will not be able to sustain the surgery or the systemic therapy. And obviously that leads to poor physiological reserve, and that compromises your energy reserves. You know, when you do surgery, the patient doesn't have any reserves to pull from, to support from the surgery, and you can't mount the typical stress response to the patients. So this is when pre-rehabilitation comes in. Most of you probably have heard about this. It's about 3 elements of nutrition, exercise, and psychobehavioral. So if you have a patient with especially liver mets with a high tumor burden, it's very important to emphasize on nutrition, to add on the protein intake, whether from diet or whether from supplements, and obviously exercise in terms of strength and aerobic training, and always address the mental health, because this patient could be depressed, could be anxious, and let me tell you, if you do not address this, this is going to affect the post-surgical outcome and eventually the overall survival as well. So this starts from the time we see the patient in clinic until the patient completes the adjuvant treatment, all right? And obviously this has shown to reduce complication and improve overall survival. So these are 3 components like I mentioned earlier, and obviously the importance is to increase the functional capacity of the patient. So this is a very nice diagram. Let's say if you plan to hike Mount KK today, you can't do it tomorrow, right? It will take time. You know, you may need to go to gym, you may need to go on a high protein diet, you may need to go for some exercises, increase your endurance, and then you go. These kind of patients that we're talking about are going to the battlefield to battle cancer. So you need to charge them, you know, charge them up until they're full up in terms of battery, and then they go for the surgery. And then the battery will drop. you charge them again for the adjuvant therapy. The battery will drop, and then you charge them back. That is when you can actually, aim what you need to achieve in terms of overall survival. At this current modern era of medicine, I feel benchmarking ourselves in terms of success of surgery is not the way to go. If we need to benchmark ourselves on the success of the patient achieving the overall survival that we intended to have from the start of the surgery. So for example, if we remove the colon and the liver mets and the patient succumb in 4 months because of complication, that is not success. If that reason for that succumb is because of a poor patient that we had prior to surgery. So we need to optimize, get a good patient with good systemic therapy and surgery, and the patient achieve the overall survival. That is what success is all about. So take-home message number 3 will be start your pre-rehab early, emphasize on nutrition, physical therapy, and mental health. So in conclusion, obviously, this liver mets in a background of colorectal cancer is not the end of the world. It is not a death sentence. If you give treatment tailored to the patient, like what we have mentioned, it will be beneficial. So earlier, the myth gave you fear, and now probably there is a rays of hope in you guys that the colorectal liver mets has probably met its match. Thank you.
Well done. Thank you, Mr. Tharveen. So I think I like the take-home messages that has been presented just now. So just to recapitulate to students, all right, I think the keyword here is multidisciplinary team meeting. When dealing with complex diseases such as colorectal liver metastasis, you have to break the barrier, start talking to your oncologist, start talking to the radiologist. And then another important aspect that I would like to highlight again here is the comorbidities and nutritional status of the patient. This is what I always emphasize during my bedside teaching with all of you. Don't forget about the diabetic control, for example, hypertension control, for example, and to perform a nutritional risk assessment. So at this moment, I think you might start to wonder, when dealing with colorectal liver metastasis, we have two sides of problems, right? So do we remove the colon first, followed by the liver metastasis, or vice versa, or we remove both colon as well as the liver metastasis as well? So to understand this topic better, I would like to invite the next speaker, Mr. Yong, to the stage.
Yep, good morning. So my topic is very specific. I just want to tell you how you want to manage colorectal liver mets, his strategies and his logic behind it. So before we start, why you want to manage this colorectal liver mets? Why this liver mets is so interested in our colorectal cancer? Why not other mets? Why not lung mets? Why not lymph node mets? Preferring like para-aortic nodes mets? Why liver mets? Because I have no disclosure here. So why liver mets? Because first time they found out that oligometastasis, like single mets for colorectal cancer, actually is a distinct clinical entity. It can achieve cure in a patient with liver mets. Pulmonary mets, yes, they are trying to achieve cure also with oligometastasis with pulmonary, but liver mets have established well. Is how my colleague presented, is actually increased the overall survival by 40%. So if you treat properly with a systemic chemo and surgery, it actually can give cure to the patient. So the main endpoint is always this. Our principle of treatments, always to prolong overall survival, achieve are not resection because we are surgeon. Then we want to achieve a disease-free survival and also local recurrence control, and last but not the least, to improve the quality of life of the patient. So a few terminologies that you guys have to understand is synchronous, metachronous. So it's always discussion among all these terms when you heard about synchronous and metachronous. So in our synchronous, according to this European a group of expert group in oncology surgery, so they're thinking of synchronous liver metastasis is detected at or before the diagnosis, but they divide the metachronous into early and late metachronous metastasis, which is within 12 months and more than 12 months. Okay, this is very important because the treatment actually will base on this, either the synchronous liver metastasis or metachronous metastasis. Sorry. Okay, then we turn to, because I'm a surgeon, so I need to know whether I do a laparoscopy or not. So actually laparoscopy is safe. And then if in an expert hand, you actually have no different, no inferior to open liver surgery. Colorectal surgery, always we do laparoscopy until proven otherwise. So we will never easily open the patient unless we got complication or we can't perform laparoscopy. So what are the options actually? Okay, if we look into the literature, there's a lot of algorithm that is given by many literature. So this is the first algorithm they give. This is the first one actually from Colorectal Liver Mets World Journal Clinical Oncology. In 2020, they come up with this. They're always divided to asymptomatic and symptomatic for the primary cancer. Then only they think of either liver can resect or not. So it means that they always go for colon first before they go for liver. So in this, after the resection, they will try to figure out what are the treatment best for each of the condition. So this early stage, when 2020 they come up with this diagram, they divided by asymptomatic and symptomatic. Then comes our textbook. So this is one of the textbook in our American Society of Colorectal Surgery textbook. So this one actually, as shown by my colleague, we also think is either symptomatic or non-symptomatic primary. We always look in the primary resection before we go for liver resection. However, now this is a however, because primary resection is not a must. It's not a must. Like, it have to remove, but it's not a must to be a first. You can remove the liver first before you remove the primary. So this is what my talk is. So this is the algorithm that or the diagram that I already compound in all other study. So I also divide to asymptomatic primary colorectal cancer and symptomatic primary colorectal cancer. So in asymptomatic, as you know, there's no symptom, patient is only finding from the scope. But symptomatic is, like my colleagues say, is bleeding, perforation, obstruction. Now, then you have to intervene with the primary first. Every time the primary got problem, you intervene with the primary first. So after you intervene with the primary first, then you decided whether this liver metastasis, then you instead of finding there's a liver metastasis, either it's resectable or not resectable. So in this diagram, if it's not resectable, usually we treat the primary. After that, we give a systemic chemotherapy. Then we assess using imaging. So if can't be resected, then yes, go ahead, palliative care. So, but if it's resectable, then I'll tell you the options of which surgery to be done first, and then why it be done first and better than others. So let's say when it's a resectable tumor in a symptomatic CRC. Sorry, you guys can see, right? Because this is not a very busy diagram. I think you guys can take a picture and then go back and read. So this is a resectable liver lesion. Then you do an oncological resection of your primary tumor first. Then after that, you go for systemic therapy, chemotherapy. Then after that, if it's still resectable, then you go liver resection preferred. So RFA, MWA, the SPT, all these technique to remove the liver lesion, it's like the diagrams show, the survival rate is actually lower because the tumor either is not resectable that much, or the tumor is too big, or they cannot achieve the future liver remnant. So they're trying to reduce it by using all these RFA, MWA, so that they can achieve more better survival outcome. Actually, overall survival is reduced as the time we go by. But liver resection is the one and the most, when you resect, it's get better overall survival, the best overall survival we can get. So this is for symptomatic, but it's asymptomatic. Now, this very interesting question is when there's asymptomatic, but the liver is resectable. Both are resectable together. Should you resect first or should you give chemotherapy first? So this is our case. Okay. Neoadjuvant chemotherapy for a resectable tumor. Actually, there's no survival benefit. Okay, but it might help in more than 4 liver lesions and can improve a R0 resection. Okay, R0 resection is a complete resection, macroscopically and microscopically tumor. Okay, so it's a complete pathology resection and can better progress-free survival. Okay, progress-free survival means that from the onset, you're having the complete cure of the disease of the tumor until you recur back. Okay, it's different for overall survival, but overall survival is when you die, either not die of cancer, but die of other things, like pneumonia, like your DVT, PE, MI. Okay, so the problem with a neoadjuvant chemotherapy is it will cause chemotoxicity. Okay, you might mention the term of blue liver, yellow liver, post-chemotherapy. All this is a problem to delay the surgery. In a resectable tumor, if you have this complication, you delay the surgery, the disease might progress. So when it progress, you become deemed unresectable. So this is a two-edged sword. So neoadjuvant therapy for a resectable tumor, either yes or no, is still debatable. Okay. However, for non-resectable liver mets, we always give a systemic therapy to reduce it so that we can deem it to resectable. So for this surgery option, now, these are the options of surgery. There's 3 options that you can choose. One is cut both. The other one is cut liver first, then cut colon. The third one is cut colon first, then cut liver. Means cut primary first, then cut the liver. Okay, cut both. What are the good thing about you cut both? Actually have a low morbidity and mortality if there's a minor hepatectomy. Means that less than 1 segment you're cutting. That actually has shortened the hospital stay. This is according to a literature study. However, if you cut more than 3 segments of hepatectomy, then the surgery have a high mortality and morbidity. And you have a worse progression-free survival as well. And also worse medium overall survival. So all these are proven if the surgery do simultaneously has more cons than pro. For the liver first, actually there's no long-term survival and major morbidity benefit in compared to other approach. You can do a liver first, you can do a primary first, there's no long-term benefit. However, there is one benefit when you don't miss the window treatment period. Means that your primary tumor needs a chemotherapy at least 3 months to control. Then only you go for liver. But at that time, if your liver doesn't respond, it will become progression. So for a resectable disease, become a non-resectable disease, then patient become palliative. Okay, bear in mind, this is a stage 4 disease, and our aim is curative. We are not going to palliative intent. So whenever we can achieve early curative, we go for it. So usually, liver first surgery, if in the case that if there's no long-term benefit between all the approach, then liver first surgery might be beneficial if you do it early. Okay? The third one always is primary surgery first. So primary surgery first, usually in symptomatic situation, then you do a primary surgery first. But if it's equivalent, then you do both. Okay, so all these are the choice that you can make. Okay, in colorectal liver mets, it's still debatable whether all these 3 have its own benefit or own overall survival, or each one is comparable better than which one. But all these 3 are viable choices that you can do. So if you can offer one of the choices, then it should be fine. The overall survival and oncological outcome is actually the same for all. Then, last but not the least, because this is a surgery, once we've done the surgery, we always talk about adjuvant therapy. So all post-op patients will benefit from adjuvant therapy. even though a short course of 3 cycle, a long course of 6 cycle, it will benefit. And it will improve the overall survival, and patient will have a disease-free survival as well. Okay? So that's all. Thank you.
Right, thank you, Mr. Yong, for the presentation. So in essence, regardless which choice that you choose, you have to weigh the risks and benefits of each of the choices. It has to be backed with evidence. The next one is about liver. You might want to ask, after we have resected the colon, we need to resect the liver. So what are the important components or considerations before we embark on liver resections? What are the preoperative investigations? What are the possible risks and complications as well as benefits of a liver resection? So to understand about this topic better, I would like to invite the next speaker, Mr. Farul from the Hepatobiliary Unit.
Assalamualaikum, good morning. Can you hear me? Okay. Okay, so I'm the fourth speaker. So some of these facts are a bit of a repetition, so it shows the emphasis of these facts to you guys. So I think as mentioned by the first speaker, colorectal cancer is second most common malignancy in Malaysia after breast cancer. This is colon cancer. And it is the leading cause of liver metastasis. You heard of synchronous and mentachronous colorectal liver metastasis. It has its significance, right? If it is a synchronous, it tends to be more aggressive nature. And if it is metachronous, it's slightly more benign, okay? And unfortunately, in terms of incidence, majority of liver metastasis in colorectal cancer is synchronous kind. So the treatment has to be a bit more aggressive. And for liver metastasis, the only curative treatment is liver resection. And plus with a multidisciplinary team management, where you have to combine with oncology and of course the colorectal team. In a multidisciplinary team management, there is no primary team. Every discipline is a primary doctor in managing this patient. So looking at the outcome, I hope we managed to convince you that liver resection provide benefit to this stage 4 patient. So I think studies have shown with liver resection and chemotherapy from 5-year overall survival of 50%, we have improved to 60% with the advancement of chemotherapy. And if at all they develop recurrence, it is only about 30% will eventually develop recurrence, and the time of recurrence between 18 to 24 months after the resections. So what are the factors that will affect the survival of this patient? First of all, the number and the size of the metastasis. And during the surgery, do we manage to remove everything? And how does the body respond to the chemotherapy? This will depend on the biology of the cancer. Do they have RAS or BRAF mutations? Is there any extrahepatic metastasis? And the timing, whether synchronous or metachronous. So I think the previous speaker have mentioned if you have cancer and if there is a recurrence within the first 12 months of resection, why do you still consider it as synchronous tumor, not metachronous? Where you were aware of metachronous means what? It's liver metastasis after resection. This is because they have found that if you have a tumor recurrence within the 12 months, the aggressiveness is similar to if you found the liver metastasis together with the colon cancer. That's why we take, if there is a recurrent within 12 months, you consider that as a synchronous liver metastasis. Okay, so how do we select whether this liver metastasis is resectable or not? First of all, we have to see whether the primary, is it resectable or not? If the primary is so advanced, it is unresectable, maybe the benefit is not so much to do the liver resection. And secondly, is there any other extrahepatic liver metastasis? And then if the primary tumor is resectable, we will look at the liver and the size of the tumor. And then we have to estimate whether after the resection, is there enough liver volume to sustain life? And for that, the pre-op workup would have to include imaging, CT scan, liver 4-phase or 3-phase. This is to identify how many liver metastases there is. And sometimes it is equivocal. And the images were not clearly defined whether this is a liver metastasis or is this a hemangioma or is this the hepatocellular carcinoma. So when there is doubts, we have to do MRI to clarify. I think this one Dr. Farhan can explain. And if there is any suspicious lymph nodes metastasis or if there is a possible recurrence at the primary site, and we cannot really identify that from the CT, then we have to do a PET-CT to really clarify whether is there any extrahepatic liver metastasis. All right, once we have identified during MDT, we decided for a liver resection, then it's time to do, to assess is there enough volume after resection. And this, we need to do CT or MRI to measure the liver volume. From this CT or MRI, we can establish the size of the tumor and estimated resection volume. And after that, how big is the liver after resection? And is this enough? So for a normal liver, you require 20% post-chemotherapy, considering possible chemo-induced liver injury. You need at least 30% liver volume. And if this patient have a concurrent liver cirrhosis, you need 40%. So from imaging, you only have a morphological idea of how much volume the patient have post-resection, but you don't have an objective data or evidence to suggest the remaining liver is going to be function. So that comes ICG. Right, ICG is a biochemical test that you give to the patient, you inject to the patient, and then after 15 minutes, you use volumetry to identify how much ICG remains in the body. Ideally, ICG will be metabolized by the liver, all right? And after 15 minutes, the amount should be less than 10%. So if it is more, that means the functional liver is not so great. So in certain center, they only have either they have imaging or they have ACG. But if there is a center who have both, they can accurately calculate the liver volume in terms of size and the functional using a formula. Okay. So lastly, I think if a patient like in this case, which had to go neoadjuvant chemo, there is always a risk of chemotherapy-induced liver injury, which prevent the patient to proceed with further liver resection. So we need to assess that prior to surgery. Timing of surgery, like Dr. Yong mentioned just now, it depends whether you do the liver resection and the colon resection together, or you do in two separate stage. In this scenario, I think the primary resection is a major operation where you have to do liver bowel resection with on-block resection of the muscle as well. So I think that takes hours. So due to a very long surgery, the liver resection was done as a second stage in a different setting. But if it is a small tumor, very mobile, and you have a 5 centimeter liver malignancy, yes, why not? We just do in one surgery together, right? So yeah, I put this here in my slide because the role of neoadjuvant does affect our decision to operate or not to operate patient with liver metastasis. By neoadjuvant chemo, if in the beginning the liver metastasis is so big, the future liver remnant is not enough, you may reduce the size and change from unresectable to resectable after neoadjuvant chemo. Second, it is early assessment of the tumor biology. If it responds, maybe this is a good candidate for liver resection. If it is not responding, maybe it is not really a good candidate. But this will be determined during the MDT. Eradication of macrometastasis, improving surgical plan is among other reasons for neoadjuvant chemo. However, this is not without any risk. As I mentioned before, there is always a risk of chemotherapy-induced liver injury. So if this happens to the patient, unfortunate, we cannot proceed with a therapeutic resection. And because of that, sometimes after complication from chemotherapy, it also will delay the surgery and warrant patient for palliations. Okay. So how do we decide in doing the surgery? The goal is always R0 resection or completely remove all the tumor. So there are two types of liver resection, anatomical or non-anatomical. I think if you can refresh your memory with your anatomy, the liver is divided into 8 segments, 1 to 8, and they have their own specific blood supply, all right? So if it is a huge tumor involving left or right side of the liver, we do anatomical because there's no point of trying to remove the non-anatomically means you just remove the tumor only without, how do I say, because it's too big, you cannot just remove that tumor. The blood supply will be affected, and the remaining liver that you left behind is going to be die due to ischemia. But if you have a small tumor, yes, you can do a non-anatomical. You just remove that particular lesions only. So for an anatomical resection, we will identify the blood supply, ligate it, and then we will see the area of infarction, and we use that line as our guide to remove that segment of the liver. Okay, sometimes you have multiple tumor, one big and one small. For example, you have one big tumor on the left lobe of the liver and one small tumor on the right lobe. So we do resection of the left lobe, and that small particular liver lesion we burn with ablation. Ablation just means there is a one needle probe. You poke the lesions and you burn it. So this is one of the way. Either you can cut the tumor or you burn it to treat the liver lesions. So in the case where the future liver remnant is insufficient and this patient is young, strong, good future, so but then despite of neoadjuvant, you cannot shrink the tumor to a small size. So another way is you make the future liver remnant bigger. How do you do that? We can do ALPS procedure where we dissect the portal vein, leaving the hepatic artery and bile duct there, and cut half of the tumor and leave it inside the body for 8 weeks. And by the meantime, the remaining liver will grow bigger, and hopefully by then it is big enough to sustain life, and we proceed with the liver resection. This is one. Another way is we embolize the portal vein of the site of the liver metastasis, and by then it will also allow the contralateral site to become bigger. Right? These are among the options for us to really, if we really determine to do a liver resection for this patient. Okay, coming to the case index, this 57-year-old gentleman initially presented with intestinal obstruction. CT scan have showed there is a descending colon mass with synchronous liver metastasis. I think you have seen the images shown by Dr. Farhan. So he underwent decompression surgery, and intraoperatively the tumor was found to be fixed and unresectable. So he had neoadjuvant chemo for 8 cycles, and upon reassessment, the tumor can be resected and underwent 2-stage procedure, open anterior resection, and followed by non-anatomical resection of segment 7 and 8. I think earlier from the CT scan shown by Dr. Farhan, there is one small lesion at segment 6. If you remember, so that particular segment, I think after reassessment of MRI, it was deemed to be indeterminate. So it was considered not to be liver metastasis. So I think the subsequent surveillance CT, the focus should be based on that particular lesions. Yeah? Okay, so for key point, colorectal liver metastasis is a treatable disease with 5-year overall survival of 50 to 60%. The primary malignancy has to be resectable to ensure good overall survival after liver resection. Pre-op workup include good liver function based on liver function tests and sufficient estimated future liver remnant based on volumetry and ICG. And patient compliance to adjuvant or neoadjuvant chemotherapy is very important. Okay, thank you.
Our goal in managing cancer patients is always about overall survival and disease-free survival. And I think what has been said just now, liver resection does improve overall survival and disease-free survival of the patients, regardless which technique of liver resection that you or surgeons chose, right? So another important armamentarium in treating cancers is chemotherapy. So for the next speaker, Dr. Khairiyah, I think she will describe to us, especially to medical students, about chemotherapy regime. What is the difference between neoadjuvant and adjuvant chemotherapy? What are the factors that is taken into consideration to choose patient suitability for chemotherapy? And for that, I would like to invite Dr. Khairiyah to the stage.
Assalamualaikum warahmatullahi wabarakatuh. While waiting for my slide, I can see a few of you already sleeping. So I'm not sure whether this, CPC is really relevant to you, but I need to remind all of you, you will see more and more cancer patients in future. So you better pay attention to my lecture. Right, I'm Khairiyah. I'm a clinical oncologist in Department Radiotherapy and Oncology. Right, so if I may just recap from the previous speaker that we, we actually managing the borderline, not inoperable, borderline resectable metastatic disease. And after we discuss in MDT, we subject patient for systemic therapy, and we managed to downsize the tumor, and then we discuss about further management for this patient. Right, a little bit of epidemiology. So I'm pretty sure that you know that colorectal cancer is one of the commonest cancer worldwide and also in Malaysia for both male and female. And about 25% present with metastatic disease at diagnosis. And common metastatic site for colorectal cancer is liver, nodal, lungs, and sometimes it can go to peritoneum bone. Yeah, right. There is a theory of seed and soil in oncology, meaning that certain tumor tend to go to certain organ. Okay, for example, like colorectal, as I mentioned, typically goes to the liver and lungs. For breast cancer, it depends to the subtype. For ER positive, hormonal positive, it tend to goes to the bone, and usually the progression is a bit slower. But triple negative goes to the organ, and it's more aggressive. HER2 positive typically goes to the nodal and brain. Yeah, so different cancer behave differently. Okay. And I also would like to emphasize the importance of the molecular profiling, because now we are in era of the advancement in oncology treatment, so we don't just rely on chemotherapy only or cytotoxic drug. We're also now talking about targeted therapy, immunotherapy, and all that. But I would like to remind you, in colorectal cancer, chemotherapy is still very relevant and the backbone treatment. Okay, just now I mentioned about the molecular workup. So this is what we call actionable biomarkers. Okay, so the very least for metastatic disease, we need to do the RAS testing or extended RAS. We can call it KRAS and RAS, yeah, because we want to determine whether this is wild type, whether this is mutated. And also in colorectal, it's very important to know the sidedness. Is it left side or is it right side? Because we know that for the right-sided usually confer poorer prognosis compared to the left side, colon CA, yeah? And of course, it's essential for treatment selection in oncology. Okay, we can never work alone, right, in managing cancer. It's always teamwork. We need a good teamwork. So in MDTs, it involves multidisciplinary team, yeah, to manage a cancer patient. Yeah, it involves oncologists, colorectal surgeon, involve radiologists, IR, pathologists, and other specialty. Okay, so when we discuss about this kind of case, we want to decide the resectability of metastasis. So we need to decide whether this is upfront resectable or not resectable or borderline resectable. Where is the site of metastatic lesions? Okay, and how many lesions? And what are the systemic therapy plan? Yeah, and then we need to decide whether this patient subject for surveillance or palliative care. So oncology treatment strategy is based on, as I mentioned, the molecular subtype, the sidedness, performance status, so very important, and the disease burden. And from there, we need to determine the goals. Are we prolonging survival? Are we actually just want to control the symptom, and are we actually preserving quality of life? So in oncology, we not just emphasize on overall survival or progression-free survival. We also emphasize on quality of life. It's so very important, maybe not to us, but to patients, because they have to live with it. Okay, I don't want to go in detail. I think you already knows, right? The synchronous, metachronous, metastases, oligometastasis. You just need to, familiarize with this term. Yeah, oligometastasis basically is low burden disease. Okay, so to speak, it's, limited lesions. 1 to 5. Actually, there is no absolute consensus about it, but you just remember it's a limited disease. Less than 5 lesions. And not more than 2 metastatic sites, okay? But advanced metastatic meaning that this is a, unresectable disease, okay? It's florid, and you know that this kind of case is not a candidate for curative. Okay, consideration should be given to relevant factors in the oligometastatic setting, because this kind of patient that we want to aim for cure, okay? So it very much depends on the disease factor, surgery factor, and patient's related factor. Okay, and I want to emphasize about patients-related factor because this is something that we always miss. Okay, we always discuss about how many lesions, okay, the sidedness, the molecular, the technicality in surgery, but we sometimes forgot to assess the patient because patient comes in many shapes and a different background and demographic. We need to assess whether the patient is fit for treatment or not. What's the patient's age? What are the comorbidities? Okay, how the fitness, even the way how patient come into your clinic, also you can gauge how much he or she can tolerate the treatment. And the way patient talk to you also can tell whether this patient has a lot of anxiety or this patient has compliance issue. So you need to sit and talk to your patient. If you want to be a good oncologist, you need to, lend your ears, be a little bit busybody, ask about them, ask about their social support, how's their financial issue and all that, because it will determine the compliance of the treatment. Yeah. Right. So managing stage 4 cancer is the whole chapter itself. So I don't want to go in detail in this because our focus today is dealing with resectable metastatic colorectal cancer. But this is how it is. There are so many guidelines out there, but this is coming from ESMO. Okay, so we have to go through patients' demographic, the molecular testing, whether it's a RAS wild type or mutated, it's BRAF mutated or wild type, and the MSH status. So this will determine the systemic treatment that we can offer to the patient. But having said that, majority of patients are, will benefit from chemotherapy. So chemotherapy is still relevant even in the era of advancement in immunotherapy because not many patients actually fall in this category MSI high, that might benefit from immunotherapy. Majority still actually benefit from chemotherapy. Okay, what are the role of neoadjuvant chemotherapy in metastatic colorectal cancer? So actually there are many guidelines out there. There is a lot of RCTs. You know what is RCTs? It's randomized control trial and meta-analysis from these RCTs, and it can be a bit daunting. So the idea of giving neoadjuvant chemotherapy is actually coming from the observational data showing there is a trend of survival or PFS benefit in giving neoadjuvant chemotherapy. However, there is a contradicting, finding in the RCT and meta-analysis. As you can see from table here that I basically summarize the main outcome from these RCTs. Yeah, if you can see here, there is some actually shows improved PFS. Some actually shows the addition of the anti-EGFR shows worsened PFS. Okay, so there is no exact consensus, but actually there is a trend towards showing improving at least disease-free progression and little bit of survival. Yeah, but of course the patient selection is so very important here. Okay, perhaps this is the most important slide or algorithm. If you can forget all my lecture, maybe you can just remember this diagram. Yeah. So how do we select? So I make it a bit more, a simplified version compared to Yong's just now. Okay, so how we decide, okay, whether this is, whether we can give upfront chemo or not. So we need to, go through the images and decide, okay, is this unresectable or borderline resectable? Okay, kalau this patient is unresectable or borderline resectable, then yes, we go for initial chemotherapy. Okay, but if this is resectable, we need to determine whether we are dealing with rectum or colon, so, because it's different. Rectum, there is a component of radiation therapy, so perhaps we can offer radiotherapy or chemoradiotherapy in rectum. But for colon, you need to decide, okay, how many metastatic lesion is there? Okay, whether there's a substantial disease in both lobe or just in one lobe. okay, and whether there's a suspicion of potent node involvement or extrahepatic metastasis, what type of mutation, is it RAS mutated or wild type, or BRAF wild type or mutated, and my initial chemo actually facilitate a less extensive operation. If the answer is yes, then yes, we can proceed with chemotherapy. If not, if limited disease, then perhaps we can offer initial surgery. But of course, this decision is very much depends on the discussion in the MDTs. Okay, I think yesterday you showed this form criteria. So, okay, there are many criteria. So I don't want to confuse you. So basically, these criteria shows the clinical risk score for patients with colorectal liver metastasis. As you can see here, there is no absolute one best criteria, but you can see here those who have disease. This is 1 point of age, disease-free interval less than 12 months, number of metastases is more than 1, the CA level, the age and all that, that would contribute or confer 1 point. So if you can see here, if the score is less than 2, this patient has low score, and more than that is the patient had a high score. So what are the chemotherapy regime? What chemo that we give? What medication that we give? Right. So typically we give a combination chemotherapy. Okay, the standard of care is fluorouracil-based chemotherapy plus oxaliplatin or irinotecan. Basically, there is no difference in terms of efficacy, but 2/3 of therapeutic effect is by the fluorouracil. And fluorouracil can be given by intravenous or oral. Okay, intravenous means IV 5FU, your oral is oral capecitabine. Okay, and sometimes if you want a better, faster, higher response, you can give combination of these triplet drugs, fluorouracil, irinotecan, and oxaliplatin. But in my practice, I rarely, or I never give triplet drugs to my patient, especially in neoadjuvant setting, because most of our patients are not very fit. Okay, we want to ensure these patients are fit enough to go through surgery, because remember, the more chemo you give, the more drugs you give, the more liver injury that you actually give to patients. Yeah, so keep that in mind. And how about the role of anti-VEGF or anti-EGFR? Okay, anti-VEGF you can give, but in my practice, I typically don't give, because there's a risk of bleeding, for surgery, and you need to stop the treatment at least 4 weeks prior to surgery. And anti-EGFR, as I showed you previously in EPOT trial, shows there is a trend of poorer PFS. So in general, most consensus actually suggested to avoid anti-EGFR in wild type RAS colorectal cancer. And how about duration? Generally, we give at least about 4 months neoadjuvant chemotherapy. So meaning that is about half of the treatment. Let's say you want to give FOLFOX, you give at least 6 cycles FOLFOX, and then followed by surgery, then the remaining 6 is after surgery. So that's what typically we do. But sometimes we, while waiting for the surgery time, we just continue the treatments, while to bridge the treatment gap. So key takeaway from this lecture is basically the best candidate for this neoadjuvant is patient with borderline or potentially resectable liver metastasis, especially with low tumor burden. And the goal is basically to downstage the tumor and basically to test the chemosensitivity and increase the Arnold resection rate. So the idea is giving the chemotherapy, we eradicate all the sensitive tumor, and then the surgery actually take away the resistant clones. So we get the best of both, right? And the regimen of the chemotherapy, as mentioned, is FOLFOX or CAPOX or FOLFIRI. And I forgot to mention just now, the treatment, the patient's factors also is very important. For elderly, usually I avoid oral chemotherapy. Somehow they do poorly because the toxicity is more, especially diarrhea. So usually I give FOLFOX. And the risk is a disease progression during neoadjuvant, not that high, but there is a risk that patient might actually not respond to chemotherapy, and patient just progress to, minute is progressed, and may actually delay the surgery or may not be a candidate for surgery at all. And not universally beneficial for clearly resectable mets. Usually we will advise for patient, to go through the upfront surgery. Basically, there is no one size fits all. Yeah, managing cancer patient, especially in stage 4, is very, very personalized, and we can never work alone. We need to discuss with our team members, our colleague in MDTs. Yeah, we have to tailor according to patient's profile, and all cases are so very unique. Thank you.
Thank you, Dr. Khaira. I think that was really an excellent talk. I always think that oncology is a very exciting field. You always have new randomized control trials with fancy names like origami, whatnot, etc. So anyway, I like the key points here. One of it is that it is multidisciplinary meeting, okay, MDT, which we have every 2 weekly. Rain or shine, we will have it in our department every Friday. Last but not least is the final speaker, Dr. Nick Farhan again. Interventional radiology, I think it's an emerging field, and they have skills to offer to the patients in order to improve the treatment outcome. So we are lucky that in HCTM we have such service to offer to our patients. And to shed some light about the role of interventional radiologists in managing colorectal liver metastases, I would like to invite Dr. Nick Farhan to the stage again.
Okay, I'm going to go through this quickly. So what are the roles of interventional radiology in CRLM? We can divide it into these 3 boxes. First is to improve surgical candidacy by doing these procedures. Portal vein embolization, which was touched on by previous speaker. We can do transarterial radioembolization, TARIKH, or we call it as CERT. And then we can also do, for curative intent, we can do ablation. And also for palliative intent, we can do TACE as well as the TARIKH. Okay, percutaneous ablation, minimally invasive procedure, which we do under image guidance. So when we see a tumor in the liver, we can poke an ablation needle and it delivers a thermal energy. So if you see here, based on this degrees Celsius and 4 to 6 minutes ablation, this will be the effect towards the tissue. So this is an example of ultrasound guided ablation. So from ultrasound, we can see a lesion in the segment 6 of the liver. And from this ultrasound, we insert a needle through the lesion and we deliver thermal energy either by RFA or microwave ablation. And these are the micro bubbles from heating the tissue. Okay. Same goes to CT guided. So from a CT, we can see a lesion, a small metastasis, and then an ablation needle here inserted. This is the example of RFA needle. So RFA needle inserted and burned, and we can see hypodensity, which means the whole tumor has been ablated, including ablation margin. It is best if the lesion is less than 3 centimeter in size, but some goes to 5 centimeters nowadays. And in terms of tumor number, 3 or less is always, usually shows a good result. Solitary lesion has better overall survival. We need to talk about ablation zone. So if you can see, if you remember the previous image, when we burn, the ablation zone is not really regularly round. So we need to achieve safety margin of at least 5 millimeters. Technical issues is position or location of the lesion. So if you remember, our lesion is in the subphrenic region, which is also which is one of the challenging areas. So among others are if the lesion is in gallbladder fossa, right liver tip, which is close to colon, left liver tip. But there are ways to maneuver to avoid burning these structures. Okay. Percutaneous ablation combined with chemotherapy shows significant improvement of overall survival and PFS. Compared to surgery, when the patient is not fit for surgery, ablation is an option. It is minimally invasive, less morbidity. We can deliver it as outpatient treatment. Not here yet. We still admit patient. And it has less tissue damage compared to surgery. Okay, next is transarterial treatment. Okay, if you can see here, there is a catheter inserted to the groin of the patient and then into the hepatic artery and into the tumor. So from this catheter, we deliver medications. It can be a combination of chemo drugs and embolic material. We can do this with the patient being awake, just a local anesthesia. What we want to achieve is direct delivery of chemo drugs and embolic material to the tumor, so it reduces the first pass metabolism of the chemo drugs. This is one example of conventional TACE, or we call it C-TACE. We use chemo drugs plus lipiodol plus minus embolic material. So these are liver mets, and then a catheter is inserted and we inject medications. And these are the uptakes of the lipiodol and chemo drugs by the tumor post procedure. So a lot of studies report between 27 months of overall survival from diagnosis and 9 months from TACE. And some patients were eligible to undergo surgery after TACE, which means be able to achieve downsizing. Phase 2 trial now is DABIRI, a combination of drug-eluting beads with irinotecan, and early results shows good overall survival and progression-free survival. Okay, complications. It does come with possible complications. Post-embolization syndrome is something that we can manage. Cholecystitis, liver abscess, and hepatitis. Hepatitis especially is the one that we need to be really careful of. The rest is, I think, relatively manageable compared to hepatitis. So TACE is usually excluded. If there is extra hepatic mets, usually we exclude. Usually it's good, not a good result to have extra hepatic mets if the patient is undergoing TACE. And the tumor burden of the liver, we should have a look at. And then how does the liver function, bilirubin, albumin, and if there's any portal vein thrombosis. Okay, another transarterial treatment that we can do is TARIKH, radioembolization. We inject microspheres that contain radioisotope. So these radioisotope will emit radiation with mean penetration of 2.5 millimeters. So it is quite tolerable radiation to the normal liver. So the microsphere is just radiating radiation inside the tumor with some manageable damage to the normal liver. So the good effects is, I think previous speaker mentioned about FLR, future liver remnant. So this is an example. So these are two metastases in the right liver lobe. So a TARIKH is produced, and this is the left liver lobe before and after the TARIKH. So this is something that we want to achieve, increase the size of future liver. It can avoid hepatic insufficiency, and also it may allow patient to undergo surgery. These are the factors that affects the prognosis of TARIKH. Portal vein embolization is something that we also can do. We approach the portal vein through percutaneous, and then percutaneous access of the portal vein, and then we embolize the right liver lobe. So we can also increase the left liver lobe size to become larger than allows the patient to maybe undergo surgery. Yep, same image. So To recap, these are the some of the roles that IR can play in the management of CRLM. Thank you.
Right, thank you so much to Nick. I guess we have reached the end of our grand CPC. I think at the end of the day, dear students, you have to know about colorectal cancer. It is exponentially rising. Based on the American College of Surgeons data, I think by 2030, it will be the most common cancers ever diagnosed. When you become doctors later, all right, I think you will diagnose patients with colorectal cancer. So I cannot emphasize more about colorectal cancer. So please go back and read, and during your bedside teaching later, I always remind Prof. Sharul, I always remind them, don't forget to do the rectal examination to complete the abdominal examination, okay? There is so much information that you can gather by taking good history and performing a good clinical examination. So I think the next session is the Kahoot session, if we still have time. So I would like to pass the session to the organizer. Any burning questions from the floor?